I would like to thank the SSBMT for organization of such an event. As you know, for Philadelphia positive ALL, pre-TKI allogeneic transplant was considered to be the standard of care for Philadelphia positive ALL patients. They are fit and they have a donor. But since the introduction of TKIs, imatinib and subsequent other TKIs, Philadelphia positive ALL outcome improved very significantly, up to the point that bringing the debate about the role of allogenic stem cell transplant in CR1, at least for a subgroup of patients. So the big question for treating physician and even for our patient is transplant is needed in CR1 or no. For updates on this issue, it's our debate webinar today with the title, How I Treat Philadelphia Positive ALL in Adult Post-CR1 Allo Transplant, Yes or No. And we are honored to have two eminent speakers to elaborate more on this issue. So this is a debate platform where initially Dr. Partow Kebriaei will give her presentation on the side of yes for allo stem cell transplant in CR1 for Philadelphia positive ALL. This will be followed by Dr. Farhad Ravandi presentation for no. And this will be followed by question and answer session. But before we start the presentations, we will have one question for our attendees to see what is their opinion regarding allogenic transplant for adult Philadelphia adult pH positive ALL and CR1. So we want our guests just to answer, to click on yes or no. We will have 1 minute for Talat. Can you put the question? Yes. So all our guests, please, we would like to have your opinion, what you will do for Philadelphia positive ALL in CR1. Would you go for allogenic transplant? You can click on yes or no. So we would like you to click, not to type an answer with yes or no, but please to by mouse to click on yes or no. This question will be repeated after the two presentations to see how much people they change their opinion and whom of the speakers will convince more people. So we'll give some time for people to answer. Do we have enough, Talat? So we have Talat. Can you elaborate more? Which one is okay? So we have a majority of our response here is yes for allogenic transplant for Philadelphia positive ALL and CR1. Okay, so with this, I would like to introduce the first speaker, Dr. Partow Kebriaei. Dr. Kebriaei is a professor at Department of Stem Cell Transplant at MD Anderson Cancer Center in Houston, Texas. She is a well-known worldwide figure in leukemia and transplant. Dr. Kebriaei research interest includes therapy of leukemias, including acute lymphoblastic leukemia, and has led the development of transplant program and cellular therapy. Dr. Kebriaei is heavily involved in the research and leading many clinical trials. So Dr. Kebriaei will give first debates about how I treat Philadelphia positive ALL in adult post-CR1 with yes debate. So welcome, Dr. Kebriaei.
Thank you very much. First, I would like to thank the organizers for asking me to be involved in this debate. And second, I would like to say that I'm so happy that we can have such a debate, that we have made such improvement in the therapy of this historically poor performing subset of patients that we now can think about perhaps not needing to use stem cell transplantation. So I start with this slide to remind the audience of what the expectation of survival was for these patients just 2 decades ago. So this was the UK ECOG International Multicenter trial. It was really the last large prospective study to look at the role of transplantation in adult patients with acute lymphoblastic leukemia. And as many of the audience can remember, this trial was actually initiated in early 2000. And the design of the trial was such that patients would receive a standard cytotoxic induction consolidation for transplant for ALL, and then those patients who had a matched sibling donor underwent a myeloablative TBI-based regimen. And the outcome of that study was that transplantation was still beneficial for patients with standard risk and high risk, standard risk disease. And this is a subset of patients with Philadelphia chromosome positive ALL. So 267 patients had Ph positive ALL. And as you can see, those that had a donor did significantly better than those without a donor. But the take home here is that regardless of approach, the overall survival for this group of patients at that point without TKI use was still less than 50%. In the subsequent analysis, they looked at the benefit of adding TKI. And so what you can see in figure A is that in the patients who received imatinib therapy at any point in their treatment, that outcome was significantly better than the group that did not receive imatinib. And furthermore, they showed that if you received the imatinib early in your therapy, you did significantly better than those who received imatinib late, and of course, still much better than if you received no TKI alone. When you looked at the transplant question, you can see that those patients who received a myeloablative transplant on protocol did significantly better than those who did not receive a transplant. These findings have since then been confirmed in multiple retrospective analyses. This is one large series from the European Blood and Marrow Transplantation, where they looked at 470 patients with Philadelphia positive ALL transplanted in first remission. And really the point of this study was to show that the use of TKI, and this was mainly imatinib again, both pre-transplant and peri-transplant decreased or improved all outcomes. So the risk of relapse was significantly lower with the use of TKI. Non-relapse mortality, which was a concern early on, especially in the group that went on to receive transplant, was no different. And this decrease in relapse has resulted in significantly better leukemia-free survival and overall survival for the group that had TKI as part of their regimen. So what about newer TKIs? So the MD Anderson group led this US intergroup study of patients receiving a dasatinib-based induction consolidation therapy combined with dasatinib as a tyrosine kinase inhibitor. And in this study, again, those patients who had a matched sibling or matched unrelated donor transplant were able to undergo a myeloablative TBI-based transplant regimen. All groups then underwent maintenance with dasatinib therapy. And what this study showed was that overall survival for the whole cohort at a median of about 2-3 years was about 70%, event-free survival about 60%. And when we looked at the question or the benefit of transplant, what we saw that if you did a landmark analysis, the group that received transplant did significantly better, both with respect to event-free and overall survival. Sorry about that. So the next question becomes, what about newer tyrosine kinase inhibitors? And again, the MD Anderson group has really led many of the trials with the newest TKI, ponatinib. I think there's some concern with ponatinib because vascular toxicity was seen early on, but we showed that if we reduce the dose of ponatinib, the toxicity was well controlled. So again, here, ponatinib was combined with the hyper-CVAD backbone. And the important thing here is that now with the use of ponatinib and hyper-CVAD, we're seeing not only very high complete response rates, but importantly, a very high complete molecular response rate, so very deep remissions. And so now when we look at the overall survival for these patients, we see that expected overall survival and event-free survival is consistently 70%, around 70-75%. So then the question becomes, what is the role of transplant now if we're seeing such good responses with just the chemotherapy regimen? And this is really the conversation I now have with my patients, that if our expectation with ponatinib and hyper-CVAD is about at 3 years and even 5 years is close to 70%, what are we adding with transplant in this best performing group? So this is just our own MD Anderson data, and this is what our patients can expect with transplant and first remission. And I have to say, and I'll talk about maintenance a little bit in the next few slides, but we can expect about a 70% overall survival for our patients. And so if our patients can really enjoy the same 70-80% without transplant, then this is where I struggle. And so for this group of patients, if they're CR1 MRD negative, these are patients that I think we may be able to watch without transplantation. So we can see in this summary slide, if you look at large trials, again, in the RAL study that was conducted in 2015, large numbers of patients, we can see that there was benefit to transplanting these patients in first remission. The patients received hyper-CVAD and imatinib. But when we looked at those patients that were MRD negative, you no longer saw that significant benefit to survival. In the SWOG study, again, this was dasatinib and hyper-CVAD, we talked about that there was a significant benefit to transplant in that group. But importantly, in that study, the MRD negative subset wasn't looked at separately. And then, of course, in this last iteration of hyper-CVAD with ponatinib, the event-free and overall survival is staying consistently above 70% in the group of patients who do achieve MRD negativity. So what about maintenance therapy post-transplant? So if we look at the trials for maintenance post-transplant, again, there's only one prospective study, and it was a fairly small study led by the Germans. And they looked at giving patients imatinib as prophylaxis, either prophylactically, and they had 26 patients in that arm, or preemptively. And that was defined by patients receiving imatinib once they became MRD negative post-transplant. The one important thing to note from this study was that actually close to 2/3 or more than 2/3 of patients in each group did stop the intended therapy. Nevertheless, what this study showed is that those patients who received imatinib prophylactically did have a significantly lower incidence of molecular relapse compared to the MRD triggered group. And subsequent studies, mainly retrospective and meta-analyses, have shown that there is an overall benefit to maintenance therapy post-transplant, and we follow that at MD Anderson. I think one question that's not answered is what is the optimal TKI and what is the duration of TKI that's needed for these patients? And we try to answer this just looking again retrospectively at our patients. So we've had 165 pH positive patients transplanted now with a good follow-up, more than 5 years at MD Anderson. About 59% of patients have received a TKI. The majority have an E1A2 transcript. This is really looking at patients in the last 2 decades. And what we can see, this is more characteristics. What we can see is that the majority of patients are transplanted in CR1 or CR2. The majority of patients received a myeloablative regimen, which is what I would imagine is the case at most institutions. Almost 50% of our patients were transplanted in molecular remission. And what we showed is that the 2-year overall and event-free survival for the whole group, this is including not just CR1 patients, but all patients, is about 50%. If we look at the overall survival for those transplanted in first remission, it's 73%. Again, remember, I said I used this number to try to determine whether a patient should be taken to transplant or not. So if we have a regimen that has an expectation of long-term survival of greater than 70%, I think that's when we can have this debate of whether the transplant is necessary. When we look at the types of TKIs that we've used, again, I imagine this is going to be same for many of our centers. The majority had imatinib, and more recently now they're having dasatinib and ponatinib. And when we look retrospectively, not surprising, this is looking at patients who were MRD negative before transplant. We were trying to determine the benefit of using TKI therapy. We see that there is a significant benefit to giving TKI post-transplant, shown here in the blue line, versus not, shown here in the green line. And then we try to get at the question of what is the optimal time frame for maintenance post-transplant. And what we see is that the patients, if they are given TKIs for more than 2 years, there's essentially no relapse. Whereas if we give it for less than 2 years, we still see some patients relapsing. And so based on this data, we've come with the recommendation that we would recommend at least 2 years of TKI maintenance. And I think this last figure just schematically shows why we're having this debate really at all. And that is because we are getting patients achieving such good responses to upfront therapy now that we're treating now not just transplanting patients, not just in CR1, but really now a greater proportion of our patients, at least at MD Anderson, are being transplanted in CR2. So in conclusion, from my side of the debate, is there a role for transplant in ALL? Well, first, again, I want to remind the group that we should be happy that overall we've made significant strides in the last 2 decades, where now patients with pH positive ALL can enjoy remission or long-term survival rates of 70%. And this is coming with the benefit really of these newer TKIs that are inducing deeper remissions for a greater number of patients. And we are seeing this consistently with the use of ponatinib. I think, though, again, because we now have a situation where we're seeing such good responses, then perhaps the group that's really achieving the best remission state, those who are CR1 and MRD negative, perhaps transplant, if we don't improve the non-relapse mortality, then transplant, if at best is giving us survival rates of 70% or so, may not benefit this group. And then finally, studies in aggregate do suggest a benefit for transplant maintenance post-transplant. So at MD Anderson, we recommend transplant in patients who are CR1 or beyond CR1 and who don't achieve an MRD negative state. But for those patients that achieve a complete molecular response at 3 months, we think that we can safely continue to watch them without transplant just for that group. We do recommend maintenance therapy for a minimum of 2 years after transplant. And again, these recommendations are largely based on retrospective series. And of course, prospective studies are really needed to justify these recommendations. And with that, I thank you for your attention.
Okay, thank you, Dr. Kebriaei, for the nice overview. And thank you for being on time. So next we'll go to Dr. Farhad Ravandi. Dr. Ravandi is Professor of Medicine and Chief of the Section of Acute Myeloid Leukemia in the Department of Leukemia at University of Texas MD Anderson Cancer Center. Dr. Ravandi, he is a known world figure in hematological malignancy and stem cell transplant. And his main areas of interest is on therapy of AML as well as on the rare leukemias like Philadelphia positive ALL. He is also heavily involved in research and is a primary investigator of multiple clinical trials. So welcome, Dr. Ravandi, and you will be on no debate.
Thank you very much, and I also like to thank SSBMT and the organizers for the invitation to do this interesting webinar. I probably go over some of the similar slides to Dr. Kebriaei, but I like to make the point that this, like many other areas of medicine, the question to the answer is actually nuanced, and you have to take into account a number of factors. Now, this is the study that Dr. Kebriaei mentioned. This is the ECOG MRC trial that was a prospective study before introduction of TKIs. You will see in many of my slides that there is a box that shows the median age of patients enrolled in the study and the range. And you can see this is a younger group of patients. And you see that the patients who underwent allogeneic transplant did better than chemotherapy. This is in Ph positive ALL. And as Dr. Kebriaei showed, when they did a donor versus no donor analysis, there was a benefit for donor, but it was not statistically significant. It was clearly about 10% better, but not statistically significant. So then many of times when we have presented our data, people have sort of criticized them, saying that they are single center studies. Now, I like to put this study from City of Hope. Again, this is before TKI introduction, just to give you a baseline. Now, this is again a younger population of patients, median age of 36, and they showed that with transplant for Philadelphia positive ALL in first remission, the expectation of survival at 3 to 5 years was about 50%. So that's probably our gold standard before TKI in a younger population of Ph positive patients. So then the question comes, can we do away with transplant now that we have TKIs? And you've seen slides like this before. When the imatinib was introduced to the backbone of chemotherapy for Philadelphia positive ALL by multiple groups, the outcomes improved significantly in terms of survival. Of course, with many of these studies, many of the patients or good proportion of patients had the allogeneic transplant. As Dr. Kebriaei mentioned, the MRC ECOG group also introduced the imatinib, and they did show that the introduction of imatinib to their backbone clearly improved outcomes, both for the patients who were transplanted in first remission, but also for the ones who were not transplanted. That's the box at the bottom. Let me put my pointer. So both for transplanted and non-transplanted patients, introduction of imatinib improved outcomes. As Dr. Kebriaei mentioned, the second generation TKIs are more potent and in many ways are more effective in terms of clearing Philadelphia positive cells. And this is why we introduced the dasatinib into our regimen. With this, we did show, as mentioned, a long-term survival of about 50%. And now this is a population with a median age of 55 up to the age of 80. So this is a significantly older population, but we are still introducing, producing significant long-term survival. The question is how much of it is related to transplant. Again, in this older population, in fact, our patients who were transplanted were doing worse than the ones who were not transplanted, clearly because this is an older population. And if we looked at this by age, the patient numbers are very small here, but in the patients younger than 40, the ones who did receive a transplant did better. It wasn't statistically significant, but they did better. However, in patients over the age of 40, the transplanted patients tended to do worse. So again, this is, as I mentioned, is a question that we've always been grappling with in our institution for the last 10 to 15 years, but I think there's a lot more nuance to it to answer that. Of course, we can improve the outcome of patients with the chemotherapy alone by introducing TKIs early and by giving them continuously. And this has been shown by a number of groups. The MRC ECOG group, as Dr. Kebriaei mentioned, initially introduced imatinib early in the course of their therapy. It was actually a block of imatinib after the first cycle of treatment. But then they actually brought the imatinib earlier in the course of therapy for their Philadelphia positive patients. And they did show that patients who received early imatinib did significantly better than the late imatinib, and also, of course, better than the patients who did not receive or pre-imatinib era. So the pediatricians also did this now very old study. This is now about 10 years old, but this is when they first started introducing imatinib, and they had about 5 cohorts that had different lengths of imatinib therapy, but they did show that cohort 5 that had over 200 days of imatinib continuously as a part of the treatment of the kids did extremely well. In fact, if these curves are not statistically significant, this is a pediatric population, but you can see that the patients who receive chemo and imatinib only in cohort 5 more than 200 continuous days, they seem to be doing at least not significantly worse than the transplanted patients, either related or unrelated donor transplant. So in the SWOG study that Dr. Kebriaei mentioned, we initially gave the dasatinib for 2 weeks of each cycle of 8 cycles of hyper-CVAD, but then we started changing this. We gave 2 weeks for the first cycle, and once the patient achieved remission and response remission rate was close to 95%, then everybody received continuous dosing of the dasatinib at a lower dose of 70 milligrams. You've seen the result of this. We did allow all the patients who had a sibling donor or a 10 out of 10 match unrelated donor to go to transplant. The other patients continued with maintenance, and both sets of patients did receive the dasatinib continuous therapy later. And as Dr. Kebriaei mentioned, this 3 to 5 years event-free and overall survival was excellent. This is a younger patient population. By eligibility criteria, patients will only be enrolled in this study if they were younger than 60. So this is a group that you would consider for transplant. And this is a multi-center study conducted across US. And you see that, again, younger population, but out of the 94 patients who were enrolled on the study, about 41 were able to undergo allogeneic transplant with a sibling or a 10 out of 10 match unrelated donor. And in this population, when we did a landmark analysis at days 175 days post achieving CR or CRI, this younger population of patients who received the dasatinib-based therapy did significantly better in terms of relapse-free and overall survival if they did undergo allogeneic stem cell transplant in first remission. The pediatric groups have also been introducing imatinib, and more recently been their backbone. These are both the children oncology group as well as the European study. And you can see, interestingly, the rate of transplant in first remission has dramatically declined over the years. Now they are having a lot of confidence in the regimen with the dasatinib, so they're transplanting very few patients, and they're producing long-term event-free and overall survivals that are great. I think the other reason why people are becoming confident about not transplanting is, as I will mention later, there are better ways to salvage these patients. Of course, predicting outcome by monitoring MRT can be very important. This is our first study that looked at this and showed that achieving at least an MMR or less at various time points at induction at 3 months, 6 months, and 12 months was associated with a better outcome. So the goal is to achieve a better reduction in BCR-ABL transcripts. More recently, we did a larger group of patients. None of these patients were transplanted in first CR. These were patients who had hypacvad imatinib, hypacvad dasatinib, or hypacvad ponatinib. And again, none were transplanted in first CR. And then we did look at the achievement of molecular remission. And we did show that achieving complete molecular remission, not major molecular remission, at 3 months was associated with a significant improvement in relapse-free and overall survival. So that has become our gold standard, because on multivariate analysis, the achievement of complete molecular remission is the most important factor in achieving 3-year and of overall and event-free survival in these patients with Ph-positive ALL receiving hypacvad plus TKI. This has also been shown by other groups. I'm not going to go into details, but the South Korean group have also looked at a reduction in BCR-ABL both before transplant, and essentially the goal of all studies now is to achieve a good clearance of BCR-ABL during the course of therapy. Of course, there are new strategies that are coming to look at minimal residual disease. This slide is not on Ph-positive ALL, but you're all aware that now we are using NGS for immunoglobulin or T-cell receptor rearrangements. And when you achieve a negative result by NGS, you can actually be confident that your patient is not going to relapse and will do well. And so, that will bring another question into the role of transplant. If you achieve a really reliable, highly predictive MRD negativity using a very sensitive assay, do we really need to transplant the patient? Other factors that we can look at, and we are beginning to look at this in our institution, is pre-treatment factors that may affect outcome. For example, Ikaros or IKZF1 deletions have been associated with a worse outcome in Philadelphia positive ALL. So perhaps we can actually look at those patients more carefully and think about them as being more likely to be a candidate for transplant. Of course, I just mentioned that many of the studies that have been reported are in younger patients, both the SWOG study and the MRC ECOG study. Remember, the median age was only about 40 to 44 years. But you all know that Philadelphia positive ALL is a disease of older population. And so a lot of groups have started to try to do away with chemotherapy. This was started by Italians, Robin Fo and then Sabine Kebriaei, using single-agent TKI with the steroids as initial therapy. And they've always reported high response rates, but low MRD negativity rates. The CMR rate is usually less than about 20% when they do this initial TKI and steroid strategy. The follow-up study that was reported by Sabine Chiaretti, essentially a lot of these patients, after achieving response, go on to receive allogeneic transplant or chemotherapy. So you can't completely rely on single agent TKI or minimal chemotherapy. However, if your population is old, this is a European study where median age is 69, as you see at the top, with patients being as old as 83. And here they used the dasatinib with minimal chemotherapy. And even in this older population, they were reporting about 30% survival at about 3 years, again, using minimal chemotherapy and essentially no transplant. The French look to see if you can use this minimal chemotherapy approach as opposed to chemo plus imatinib. And this study, the initial therapy was a randomization to either imatinib alone or imatinib plus chemo. And they did show no difference between the two arms because many of these patients went on to receive either allogeneic or autologous transplant. You see here at the top, the patients who received allogeneic transplant, relatively younger population with a median age of 47 up to the age of 60, did significantly better than the ones who did not receive allogeneic stem cell transplant. But at the bottom, they looked at the patients who achieved complete molecular remission. And in this subpopulation, the ones who achieved complete molecular remission after the initial chemotherapy plus TKI, the patients who underwent autologous transplant did better than, or did at least as well as the patients who had allogeneic transplant. So you can use your molecular response to even decide about the type of transplant. Of course, when us and other groups looked at the patients who relapsed after initial therapy with the dasatinib-based therapy, we found that a lot of the relapses are with T315I mutant BCR-ABL, as shown in this slide from the European minimal chemotherapy study, which you see that among the patients who they were able to do sequencing at the time of relapse, 2/3 of them had T315I. And even when they used a very sensitive test prior to initiation of therapy, they were able to show that in 10 of these patients, T315I could even be detected before you gave them any therapy or any TKI. So T315I is a mechanism of resistance in this disease, and that's why ponatinib is probably the best TKI in this disease. I shouldn't say probably, I would say is the best TKI in this disease, and that's why our group has moved on to use ponatinib plus chemotherapy in our frontline therapy of Philadelphia positive ALL. This data has been published already in Lancet Oncology, showing a very good long-term survival above 70%. And when you censor it or not censor it for transplant, the outcomes are the same. Very few patients were transplanted, but in this study, and we have had further follow-up showing that the outcome is continuing to be outstanding. As I mentioned, long-term survival here approaching 80%. So clearly, using a ponatinib-based regimen, you can achieve very good long-term survival without transplant. And as Dr. Kebriaei mentioned, one of the main reasons for this is we are achieving over 80%. This is an old slide now, is about 85% complete molecular remission with the ponatinib-based regimen. And this is the longer follow-up, again, showing that complete remission duration is 80% and overall survival is about 75% at 4 to 5 years. Finally, the question comes, well, if you use no transplant, what happens if these patients relapse? You know, traditionally, if a Ph-positive patient relapse, we didn't have many options. But we now have a number of tools that we can use. Blinatumomab, as a single agent, has significant activity. In this study, Dr. Martinelli from Italy reported 40% response in patients who were T315I mutated, and overall about 40% response in relapse Philadelphia positive ALL using single agent blinatumomab. And of course, we can combine this with ponatinib, and we have done this. And at this year's ASH, you will hear the update of the study, which is producing very significantly high response rate in both relapse and frontline elderly population. The Italians have also done this. They are using the dasatinib plus steroids to achieve the initial response, and then they use blinatumomab to clear the MRD, and they have shown that they can improve the MRD clearance from what I mentioned before, which was used to be about 20%, now to about 56% with this approach of the dasatinib, steroids, and followed by blinatumomab. And this has been associated, at least in early reports, with very good disease-free and overall survival. There's also inotuzumab, as I'm sure you're all aware of. Inotuzumab hasn't had much press in Philadelphia positive ALL, but if you look at the studies that were led to the approval of these drugs, and in the inotuzumab, there is a 66% response in relapsed Philadelphia positive ALL as a single agent. So you can actually combine inotuzumab with other drugs. We did this in this study at MD Anderson, combining it with bosutinib, that also produced a lot of excellent responses. So in conclusion, the question of transplant in first remission now has to be nuanced. I think it all depends on the age of the patient, depends on the type of TKI that you're using. I would tell you that ponatinib is the best TKI in Ph-positive ALL. And also the concern for relapse and lack of ability to salvage these patients and transplant them in second remission is no longer a question, because we have very effective strategies that you can salvage these patients. I haven't mentioned about one last strategy that we are using in our center that we will report very early results, and that's combination of ponatinib and venetoclax, which is very powerful as a non-chemo oral therapy for relapsed Ph-positive ALL, and we have seen very exciting results in very few patients. So I do not advocate to that to be used extensively. And I think that's my last slide, and thank you very much again for your attention.
Thank you, Professor Ravandi, for excellent overview. And thank you. And can we go, Talat, for survey question again? And can you also open the question and answer for our guests to ask? So this is again the same question. Would you do allogenic transplant for adult Ph-positive ALL and CR1? Please choose with your mouse yes or no. Sorry. So can we have the answer, Tara? So Dr. Ravandi did convince some people to change their mind from yes to no. Okay, thank you for both speakers for their excellent presentation, and we'll go now for session of question and answer. And until people they prepare their question, I have one question for Dr. Kebriaei. Now, when we say allogenic transplant, do you mean all the type of allogenic transplant, which means match-related and alternative, especially for haploidentical, or we are restricting this just to match-related allotransplant?
No, I'm sorry I didn't make that clear in my talk. I think one very large, significant improvement in the field of transplantation has been the ability to do haploidentical transplants, really now with lots of studies that show essentially doing equally as well as matched related and matched unrelated donors. So when we now say transplant, I would use any donor to do the transplant.
And another question for Professor Ravandi. Now, you mentioned about using blinatumomab and inotuzumab and other things, but do we have enough data now if patient goes on TKI and chemotherapy and they relapse, how will we salvage them, or how's the outcome of transplant to salvage these patients?
Yeah, so there is, a question of enough data. Of course, the studies that have been done have been very limited in numbers. I showed you blina as single agent has about 40% response in pH positive ALL. But when you combine it with ponatinib, we have close to 70-80% response rate. Also, similarly, on our inotuzumab plus bosutinib, and I would not call bosutinib as the best TKI for pH positive ALL, but in that study of inotuzumab plus bosutinib, we also had over 70% response. In small series, yes, there is data that you can actually produce a second remission. Perhaps Dr. Kebriaei could answer whether transplanting in second CR is as good as first CR, perhaps not, but still these patients can be put into second remission, even in molecular remission, and then have a transplant in second remission.
Do you want me to take the rest of that question? So that is an excellent question, and I think lots of groups are looking at that. So when we look at MD Anderson, CR2 does not do as well as CR1 when you take the groups in total. But when we separate out those who are MRD negative, the CR2 MRD negative patients do just as well as the CR1 patients. And this was also nicely reported for acute myeloid leukemia from the Fred Hutch group. So I think it all comes down to that minimal residual disease and comes to the ability of having effective salvage agents. If we have effective salvage agents like blinatumomab, inotuzumab, CAR therapies, and we have an expectation that we can get the patients into a second CR that's MRD negative, then I would feel safe watching some of those patients in first remission. And then should I answer the question that's on
Before that, and just one clarification about your meaning of MRD negative. Do you mean MRD4 and better or undetectable residual disease?
By flow, so 1 times 10 to the 1 in 10,000 leukemic blasts. I think if you have flow sensitivity that has 1 in 10 to 10,000 or 1 in 100,000 sensitivity, that's a reliable marker. Of course, I think we're all waiting to see the reliability of next generation sequencing. But I think if you have multicolor flow that gives you 1 in 10,000 or 1 in 100,000, that's reliable.
But in Philadelphia positive, it's probably better to go with BCR-ABL.
I apologize. That's right. In pH positive, of course, you have PCR testing.
So this is what I mean for PCR testing. Are you going for MR4 and better or undetectable MRD?
I mean, again, MR 4.5, which is essentially CMR, complete molecular remission. I don't think my major molecular response is not as a good indicator of good long-term outcome. I showed that before. So the goal should be complete molecular response. So it's MR 4.5 and better.
Okay. So Dr. Kebriaei, would you like to answer this question from Dr. Ihab? When do you expect to start the maintenance TKI post-allo transplant?
Yes, we start the maintenance within the first 2 months of therapy, once transplant. Once the CBC recovers, shortly thereafter I start. So within the first 2 months after transplant.
Okay, so we have another question. Maybe this will be for Dr. Farhad. We see a lot of toxicity in adults with TKIs and intensive chemo, both hyper-CVAD and pediatric inspired protocols, leading to the interruption, especially TKIs. What do you suggest?
So I think you probably use more of a BFM type regimen with perhaps a lot of asparaginase. And, for example, if you try to combine that with ponatinib, you may have risks of pancreatitis because both drugs can cause pancreatitis and liver toxicity. When we use the hyper-CVAD regimen, the main toxicity that we get is myelosuppression. And, of course, that has its own potential risks, including infections and bleeding. In general, I don't believe the myelosuppression is related to the TKIs. So except for the first cycle that I mentioned, we only give the TKI for 2 weeks and then wait for the patient to achieve remission and recover the counts. In the subsequent cycles, I don't interrupt the TKI because of myelosuppression, because of low counts. That's generally not the cause, dasatinib or ponatinib. There may be other toxicities. Of course, dasatinib has been associated with pleural effusions. We occasionally get that. Ponatinib occasionally gives pancreatitis. And of course, with those, you have to interrupt. But you should try, as I showed you, the more continuous administration of TKIs, the better likely to be the outcome. So I would, yes, definitely interrupt the TKIs if there is an obvious toxicity, pleural effusion with dasatinib, but I wouldn't hold the TKIs if the counts are low, saying that this is probably because of dasatinib. In general, that does not happen. Remember in CML days when we started using the TKIs, many people would hold the TKIs if the counts were low, but we don't do that much anymore because the initial myelosuppression is related to a marrow full of Philadelphia positive cells, which when you get rid of, you won't have as much of a trouble with the TKIs.
Do we have any recommendation regarding omitting asparaginase if we are using hyper-CVAD and TKIs?
Well, the hyper-CVAD regimen doesn't have asparaginase, so we don't use asparaginase in the hyper-CVAD regimen. We have an augmented...
augmented hyper-CVAD does have asparaginase on it.
The augmented regimen, but we don't use that for pH positive.
I see.
In fact, in our center, we have actually started we now use lower doses of chemo for all the patients. So we use what we call mini CVD plus ponatinib. So we have, yeah, that's another thing. As you get more effective targeted therapy, you are okay to start reducing the intensity of your chemotherapy, particularly in the older patients.
Okay, question for Dr. Kebriaei. What the dose of ponatinib as maintenance, and what is the risk of vascular events on long-term use?
So we use 15 milligrams, the dose that is recommended even before transplant once the patients become MRD negative. So the patients are maintained on 15 milligrams. As you saw in that last slide, we still don't have that many patients on ponatinib as maintenance post-transplant. We have not had any vascular events thus far with the patients being on 15 milligrams only, 15 milligrams daily.
And I have a question in continuation of this. Now, you mentioned in your slides that you will give maintenance for at least 2 years.
Yes.
What is the role of MRD in defining the duration of maintenance treatment? So if a patient is MRD negative post-transplant, is he the same, like I give 2 years or I give less or more in comparison to the patient who still have MRD positive?
Right. So that's a good question. We don't have a prospective study looking at that. I think that's a good prospective study to do. So our practice is everyone, regardless of whether they're MRD positive or negative, should be on maintenance for 2 years. But I have to say that if a patient is MRD positive post-transplant, that's someone that, especially if they were MRD going into transplant, I actually consider that a progression. And so that's a patient that I would give blinatumomab or more intensive therapies for them to become MRD negative. If they remain MRD positive, so they were MRD positive before transplant, MRD positive post-transplant, that's someone that I may try to continue with ponatinib if it's pH positive and see what happens to them. But if they are recurring with MRD positivity, I consider that a low-level relapse and would treat with blinatumomab.
Good.
I think I like
yeah.
to make a very quick point on that, and that, as you know, in CML, when patients become BCR-ABL negative, the studies, including the French study, is if you are 2 years MRD negative, you can consider stopping the TKI, and then even in those patients, 50% have molecular relapse. Now, of course, pH positive ALL is not the same disease, and post-transplant setting is not the same situation. But I think if the ability is there and the cost is not intolerable, for me in pH positive leukemias, you need to continue TKI as long as you can.
And the question again, in this regard, there was a question about, do you use DLI for in patients who are MRD positive post-allogeneic transplant?
So I use less and less DLI with the advent of more effective therapies because DLI is associated with 50% graft versus host disease. If a patient is MRD positive, I would do blinatumomab and TKI.
Okay, another question. What is your approach to patients who relapse post-allogeneic transplant? Do you do second transplant or CAR T cells or any other approaches?
I think if a patient relapses within the first year of their transplant, I'm not sure doing a second transplant is beneficial. And so I would send them for experimental therapies, including CAR T cells. And someone who relapses after 1 year, they often get both. So I would use any salvage to get them into a second remission. And we've had patients receive CAR therapy. And then afterwards, I consolidate with a second transplant. Unfortunately, CAR T cells, while they're extremely effective in inducing a molecular remission, the remissions don't appear to be durable, right? Most of them by 1 year, half of them by 1 year relapse. So I don't think of CAR T therapy as being a durable therapy, and I would still try to consolidate a group with a second transplant.
Good. I don't see more questions, but I have a question for both of you. What are the challenges to have randomized prospective trials for Philadelphia positive patients to compare all these modalities of treatment?
Yeah, if you were to have a debate, I can answer that first. I absolutely think we need to have a prospective study. Like I said, the last donor, no donor study in adult ALL was 20 years ago. And so I think it's important. Really, the best way to look at this is to look at it prospectively in a randomized trial.
Well, I would say that, of course, pH positive ALL is not that common a disease. That in itself causes a problem. And the fact that now we have so many different options. I know there are cooperative groups in the US who have been trying to develop studies in this disease. Now that there's different options, there's always different questions, and now we have different TKIs. Everybody has their favorite TKI. Some people are scared of ponatinib; they think it's too cardiotoxic. So it is an important thing to do, but as you said, there are many challenges.
I see. Do you have any more questions, Muhammad Talat? I could not see.
No question here.
Okay, so if no more questions, I would like to thank our great speakers for their time and for their great presentations. And I would like to thank our attendees for their great time. And again, I would like to thank SSBMT for organizing such events. And also, I would like to remind you about the second debate, which will be on Saturday, 22nd of August at 9 p.m. Riyadh time, how I treat multiple myeloma post-auto stem cell transplant. Should we give consolidation, yes or no, with, again, another two eminent speakers, Dr. Saad Osmani and Dr. Vincent Rajkumar. Again, thanks for our speakers and hope to see you soon in new SSBMT activities. Thank you for all.
Thank you again.
Thank you.
Thank you. See you.